Greetings from Ithaca, everybody. My name is Bruce Kornreich, and I'm the director of the Cornell Feline Health Center. And thank you for joining us for a very special webinar today. Before I get to the topic and introduce our very esteemed speaker, I just want to run through a couple of logistics that have to do with how things will run today. If you have questions, please enter them in the Q&A function. We'll review them and try to get through as many as we can at the end of Dr. Coggins' presentation. Of course, we're likely to have hundreds of attendees, so please understand if we can't get to all the questions, but we'll do our best to get to a good smattering of them and a nice kind of a distribution of them. A friendly reminder for those attending the webinar who want to receive New York State continuing education credits, you must be logged in for the entire presentation. Once we end the webinar, there'll be a pop-up with a survey that must be completed to confirm New York State continuing education credits. If you missed that, that's okay. There'll be a reminder sent to you via email 2 days after the webinar. Those of you who are not interested in credit, we welcome your feedback regarding our feline health programming as well. So now that we're done with the logistics, we're very excited to have Dr. Sally Coggins talk to us today about feline infectious peritonitis treatment in the United States. I have to say, I've been here for about 12 years, and FIP is one of those things, perhaps the most commonly requested topic for us to provide guidance on. And I have to say that until quite recently, this was considered to be a disease that was almost routinely fatal. So in my view, and probably Dr. Coggins would agree with me, the development of these new compounds for treatment of this really previously, well, it's still a devastating disease, but routinely fatal disease, is one of the really big paradigm shifts in veterinary medicine since I've been a veterinarian, and I graduated in 1992. So we're really excited to have Dr. Coggins, who's really one of the foremost experts on the treatment of cats with this new series of drugs. So a little bit about Dr. Coggins. Dr. Coggins graduated from the University of Sydney, Australia in 2007 and has been a feline-only clinician since 2010. She attained membership in feline medicine with the Australia and New Zealand College of Veterinary Science in 2012, was the director at the Cat Clinic Melbourne, an examiner with the ANZ CVS, and tutors for the Center for Veterinary Education. Since 2020, Sally has been completing a PhD investigating antiviral therapies for FIP, and that PhD is imminent, where she conducted a national prospective study utilizing remdesivir and GS441524, characterized the in vitro and in vivo pharmacokinetics of remdesivir in cats with FIP, co-authored a retrospective collaborative study assessing treatment outcomes of 307 cats treated with remdesivir and GS441524, and has ongoing research collaboration within the United States, UK, Germany, and New Zealand. Sally also continues to practice clinically 1 day a week at Evervet in Melbourne, Australia. So clearly, a wonderfully talented and experienced person who can speak in the clinical realm, research realm, and we're really quite happy and really honored to have her with us today. Sally, thank you so much, and we really look forward to hearing what you have to teach us. Please take it away.
Thank you so much, Bruce. That's very kind. And yeah, I'm very excited to be back speaking for the Feline Health Center. This is such an exciting space, and it's become even more exciting for people based in the US in recent months, with sort of a more legal route now to accessing some of these drugs, which has been a real barrier and still remains a big barrier in several parts of the globe. Now, I guess the primary objective for me for this talk, I'm aware that not all of attendees are going to be registered DVMs that are treating in clinical practice. But for those of you that are, I really want to try and make this as practical and help upskill you so that you feel really confident treating these cats in practice. And so there are some quizzes throughout this webinar, and they are probably a little bit more directed towards the vets in the room, but everyone's welcome to participate if they wish. Firstly, my disclosures. I have delivered a number of webinars like I'm doing tonight. Tonight your time, this morning my time, for honoraria on the topic of FIP treatment. And I guess I just want to disclose that no external group has had any influence on my research or the content of my talks. I will, however, be discussing the off-label use of remdesivir and the non-FDA approved use of GS 441524, molnupiravir, EIDD1931, Paxlovid, and mefloquine for the use in cats with FIP. A bit of a rough outline of what I'm hoping to tick off today. Essentially, I'm just diving straight into the treatment aspect of this. I'm not going to be discussing the evolution of how this came to be that we got access to these drugs. I'm not going to be discussing how we go through diagnosis of FIP, but I will direct you to some additional webinar resources at the end of this talk for that. The key antivirals and expected response rates is what I'm going to spend the most time discussing today, and the current treatment protocols that are being implemented. We're then going to go through the recommended monitoring and expected response to therapy, and when we need to be considering dose adjustments. I then want to go through troubleshooting refractory FIP cases and introduce you to those additional antivirals. And then I'm going to do some case examples to finish, hopefully, if we have time. But I think the elephant in the room, and I just want to sort of run through this from the get-go, is still around the legality of compounded GS 441524 in the US. This slide is adapted from a wonderful colleague of mine, Samantha Evans, who co-presented a webinar with me recently on this topic. And I'm borrowing this from her because it was well constructed and to the point. And essentially, compounding of GS 441524 is not legal, but it is expressly allowable by the FDA under the GFI number 2560's enforcement discretion. Now, the FDA announced their position on the use of compounded GS 441524 to treat FIP, and explicitly stated that they do not intend to enforce new animal drug approval requirements for products compounded from GS 441524. GS is under review as a substance approved for office stock. But whilst it's under that review process, it can be ordered and kept as office stock in the meantime, except for the following states. If you are residing in those following states, that doesn't mean that you can't access GS 441524 through compounding, Stokes Compounding Pharmacy. It just means you can't have it pre-sitting on your pharmacy shelf. You need to order it for the individual patient. GS 441524 remains under patent until 2029, but there have been no efforts to stop compounding pharmacies from producing this in other countries for the veterinary market. So essentially, it is legal for a DVM in the US to prescribe GS 441524 to a cat with suspected FIP through a licensed compounding pharmacy. Now, I just want to take a little pulse on the room or the attendees that are here live. If you pull out your smartphones and scan this QR code, I'm really hopeful that this quiz will work. I always get nervous introducing tech into my talks. But if you can all just sort of pull that up and just start entering in which countries you're tuning in from. I'm sort of assuming most of you are from the United States. And I just wanted to make sure that I'm not surprised to see we've got Canada, but I'm just interested in other parts of the globe that may be tuning in, because the application of this is quite independent of exactly where you're tuning in from. Okay, great. So yeah, a lot from the US as expected, but we're definitely seeing Canada, Brazil, Chile, Australia. Hello, fellow Australians. Germany, cool. All right, so it's a bit of an international mix. Excellent. Let me see if I can move. So this is sort of a bit of a map that I created in the last couple of months of just who can get GS from where. Given the majority of attendees are probably going to be tuning in from the US, Stokes Pharmacy is the compounding pharmacy that is doing GS 441524 tablets, and they are using the exact same formulation as Bova Compounding. So Bova are who kind of started all of this in Australia back at the end of 2020. We got access to compounded remdesivir as a parenteral formulation, and then oral GS 441524 The UK quickly followed because Bova have operations in Australia and the UK. And from the UK, Bova can export to a number of different countries, which are sort of starred here in the purple, the darker purple stars. For Germany and Switzerland, they do have access to Bova stock, but it's for research purposes only. And for our New Zealand colleagues, they get remdesivir from Optimus Healthcare. So it's gradually increasing the number of countries that have access to well-formulated compounded versions of these drugs, which is really encouraging. I've got another quiz for you all. If you can keep your smartphones out, and it may just flick, if you keep the browser open, it may just flick to the next one. But for primarily the clinicians that are in attendance, I just want to know who right now would feel confident treating a case of FIP. If you were presented with something tomorrow or tonight, who is going to have some clue of where to start? Okay, great. So I'm glad there's people that are not confident are in attendance, because hopefully I can help increase your confidence. It looks like there's sort of a few that definitely have some experience, which is amazing. Awesome. Okay, great. Thank you all for your contributions. That just helps me know where to pitch this a little bit better as we move through. So with the drugs that I want to introduce at the forefront of all of this are these two compounds, remdesivir and GS-441524. And it's important to recognize that these drugs are linked. Essentially, remdesivir is the prodrug. It's a nucleotide prodrug of GS, which is the core nucleoside. When we give remdesivir to a cat, it gets turned into GS, or we can just give straight GS to a cat and we get GS. But ultimately, that GS is then further hydrolyzed into an active triphosphate, and it's the active triphosphate that is the actual antiviral component. But it's just important to be aware that if we give one, we sort of get the same result, is essentially the methodology behind how some of these protocols work as well. And I guess just to introduce as well, there's another pairing, which I will touch on briefly, which is molnupiravir and EIDD1931. It's a similar concept where molnupiravir is the prodrug and the EIDD1931 is the core nucleoside. Now, these are just some recent publications that have purely used the compounded formulations. And this talk, I am very much focusing on the use of the compounded formulations and off-label access to human drugs. I will not be discussing the unlicensed formulations, which are definitely still out there and may still be your only avenue, depending on parts of the world and the US that you're sort of coming in from. But ultimately, in terms of the expected survival rates that we can achieve with these drugs, our prospective study from the University of Sydney, we achieved an 86% survival to 6 months. This was the retrospective collaboration that the amazing Sam Taylor sort of headed up, wrangling 307 retrospective histories from between mainly the Australia and the UK. We achieved 84.4% survival in that study. And then another retrospective study from the Royal Veterinary College achieved 81.3%. There are prospectives underway in Europe, mainly with Munich and Switzerland. So Munich, Germany, and Zurich, Switzerland, but also the University of Bern have a prospective all using Bova formulations. And there was a recent publication from our colleagues at the University of Munich. It's an exciting new publication looking at shorter duration of treatment, comparing 6 weeks to 12 weeks of therapy. Their overall survival rate was 95%, but just a little caveat that the selection of those cases was a little bit biased towards the less severe forms of FIP, whereas these other publications included moribund animals because we had parenteral remdesivir, so we could give an IV, whereas the Munich study, they were only studying oral, and so animals needed to have a competent swallow reflex and to be in a sound enough state to be able to receive oral medications. With regards to our study here at the University of Sydney, I have updated survival data for those cats, and we achieved 83% overall survival to 18 months. A lot of these cats now have just hit their 3-year long-term survival mark, and I'm still in contact with a lot of their owners and receive delightful photos of fat, happy cats, which always brightens my day. The one cat that died after the 6-month mark likely was due to neurologic complications of congenital pituitary dwarfism, but we were unable to do a postmortem in that animal, so I couldn't 100% exclude FIP being involved, but it was considered unlikely. I think another key statistic that is helpful to me as a clinician, though, is that the majority of cats that we start on treatment, in terms of where we see that mortality, it tends to happen very early on in the course of treatment. And whether this is due to the fact that their disease is just too severe to reverse, or we need to optimize how we're managing these patients, which again is why it's so imperative that vets are driving the treatment of these diseases, and that we have these cats in our hospital environments when they need to be. If your cat survives for the first 48 hours, then the 18-month survival percentage goes up to 92%. So in terms of how I, the clinician, go about presenting the enormous amount of literature to a client who I am faced with in private practice, essentially my sort of speech that I will go through with them is that FIP is a disease that historically carries a near 100% mortality rate. The overall survival rates following treatment with these new antiviral drugs across the literature is between 77 and 96% of cats are going to survive. And although we've made enormous progress, we do still need to let our owners know that we don't win in all instances. And unfortunately, we do still see on average about 15% of cats that may still die of this disease. But if their cats survive the first few days of treatment, then their long-term survival chances go up enormously. And we're looking at more like 92% survival. So this is the current summary of treatment protocols with the use of remdesivir and GS 441524. All these slides will be emailed to attendees as a PDF after the talk, so don't feel like you've got to randomly scribble down all of these things. You're welcome to take photos or screenshots as I go, though. I don't have any problems with that. This changes regularly. It's stayed the same for the last couple of months, but it's really important to keep referring back to the most recent presentations, because we're having literature published in this space on a weekly basis. And there's some much bigger prospectives that are drawing to completion and are in the pipeline for publication that's going to continue to modify and adapt how we're approaching treatment for this disease. But ultimately, whether you're giving remdesivir or you're giving GS, we use the same dose rate. The main distinguishing thing that you need to establish as a clinician when you're trying to determine the dose rate is going to be whether or not these patients have ophthalmic or neurologic involvement. Because if they're plain effusive cases or dry cases, so granulomas in other tissues that are not ophthalmic or neurologic, then we're generally treating them with the same dose these days, which is 15 mg per kg per day. If I'm giving that as parenteral remdesivir, I do that once a day as a slow CRI, and I'll discuss that in more detail in a second. If I'm doing oral GS, then you can look at doing that as a divided dose. There is certainly some evidence that suggests that we may have higher 24-hour plasma concentrations, or maintained at a higher level over 24 hours if we split the dose. The thing that's still lacking for me, though, is firm evidence that this is a plasma concentration dependent drug. So we've been sort of doing some therapeutic drug monitoring stuff, and there's a lot of variation with cats, but I can't actually correlate that variation with outcome. We're looking at doing some population pharmacokinetics, but there's another amazing group over in Edinburgh that are doing work in this space, and I'm really, really excited to see what they eventually publish. But for now, for me, given that pretty much all of the publications to date have used SID dosing for effusive and non-neurologic dry cases, and the current sort of treatment duration is 84 days. Splitting the dose is essentially asking our owners to double the frequency of administration. And I think compliance can start to become an issue depending on the temperament of the cat. So I'm very happy doing SID dosing, but sometimes to troubleshoot, I will split the dose, and I'll talk you through that subsequently. With neurologic cases, though, I do generally divide those from the start. So it's 20 mg per kg per day of oral GS, but I will generally administer that as 10 mg per kg BID rounded up to the nearest quarter tablet. I think it's important to highlight that most cases now we do treat with oral GS from day one. When you read the literature, a lot of the protocols that were first published, including my own protocol, advocated for using IV remdesivir for the first few days and then transitioning them to either subcutaneous remdesivir and then onto oral GS, or then straight to oral GS. Really, that's because of how the timeline of drug availability evolved and where our ethics applications were up to at the time. So we only had remdesivir for the first 12 months, and my ethics application was written that all these cats had to start with remdesivir. As we got access to legal GS, we had ethics allowance for me to continue to monitor cats if their vet and their owner elected to transition them onto tablets. And as we built confidence with cats outside of the prospective study, we rapidly decreased the duration of subcutaneous administration of remdesivir, and ultimately just moved to straight giving these cats tablets from day one, as long as they're in a well enough state to be able to swallow a tablet and not needing really intensive hospital support. So although the literature promotes IV administration first, I touch wood, I don't remember the last time I used IV remdesivir. It's definitely been more than 12 months because we're able to access oral really rapidly, and we're very proactive with sort of confirming our diagnosis and starting treatment. I'm not seeing these really end stage cats anymore either, which is really encouraging. So GS, if you haven't seen it, these photos are courtesy of Stokes Pharmacy. This is essentially what it's going to look like if you write a prescription for compounded GS in the US. These are a 50 milligram quad scored tuna flavored tablet. We still recommend giving these fasted. I generally withhold food for 1 to 2 hours before administration, but if these are teeny little kittens, it's definitely more toward the hour mark. It's okay, though, to give this with a tablespoon of wet food or one of those little creamy churu treats to help wash it down and to make it a positive experience for the cat. And then I'll generally reserve giving them a full meal until about 30 minutes after. We do always want to round up to the nearest quarter tablet so that cats continue to grow into their dose and not grow out of their dose. These cats will often put on a lot of weight over the course of treatment. As we'll be familiar, a lot of FIP presents in our younger cats, although we do definitely see it in cats of any age. But most cats will put on average about 1 kilo of body weight over 12 weeks. So we need to be accounting for the fact that they may gain a considerable chunk of weight between reviews, and it's important that we are rounding up and letting them grow into that dose. Bova, who supply Australia and the UK and pretty much the rest of the world that's not the US, they do also do a tuna flavored oral suspension, which Stokes are definitely in the process of hopefully launching imminently. So you will be able to titrate doses a little bit more finely with the oral suspension, which is really helpful if you are faced with cats that are less than 2 kilos. The quarter tablet increments do become quite a big jump in dose rate, whereas the oral suspension gives you more flexibility there. And this, again, is a slide that I credit to another amazing colleague, Samantha Taylor, just reminding us to make this think about compliance and help our owners help these cats. So don't be afraid to use these creamy treats. We really do need to try and invest time in making medication time a positive part of the day for our cats and our owners. And these are just 2 cats that this cat literally on the left just licks the tablet with the churu on it because he's a ginger. This little kitty on the right was a little bit more tricky. These owners were actually crushing the tablet into the creamy treat and then syringing it back into an empty foil wrapper so that it looks to the cat like it's just a treat. However, you need to do it to make it feasible for your owners. I think it's really important that we're investing that time. And sometimes it is about, scheduling time to give your owners to be upskilling them on how to use pill poppers or oral medicating their cats. When it comes to remdesivir, I probably will fly through this a little bit quickly, but again, you can refer to the slides. Ultimately, Veterinary is the formulation that's available in the US. This is used for debilitated patients that don't have a swallow reflex. So essentially, given that it's a little bit harder to come by in the US, oral is going to be your mainstay of therapy. But if you do have a really obtunded, debilitated animal, there is an IV option that's FDA approved for human use in COVID-19 patients. Therefore, and you can use it off-label as a veterinarian. So you can write a script for this as a DVM for off-label use in your cats. The issue is it can be quite difficult to obtain, and it can also be very expensive. Ultimately, because this is an IV formulation, it's not something you're going to find at your corner drugstore. These are generally, if you're going to find these vials, they'll be in pharmacies associated with human hospitals or teaching hospitals. And it's not something that every vet is able to access from what I've heard, just communicating with DVMs over in the US. So I think it's really important to anticipate that this could be a presentation that you might need to deal with, and it would be really good to reach out to your local pharmacies to figure out whether anyone does actually stock these vials and what sort of cost you're looking at so that you're prepared. But in terms of how we prepare Veterinary, it comes as a powder that needs to be reconstituted in the vial initially, but then further diluted in sodium chloride or 5% dextrose. If you follow the manufacturer's recommendation, the final concentration should be between 1 to 2 mg per ml. I do say from a cat perspective, you probably want to aim for that 2 mg per ml final concentration, purely because of volume overload being a potential issue when we're looking to then administer this over 30 minutes to 2 hours. Now, I did note a little discrepancy, and I just want to flag that with you all. In the original slide that I showed with the summary of dose rates, down the bottom, it will say that you can give remdesivir over 20 to 30 minutes IV. That is if you're using the Bova remdesivir. If you are using Veterinary, we recommend you have to do this sort of pre-dilution step, but the general recommendation now is to give it between 30 minutes and 2 hours. Anaphylaxis has been reported in humans following rapid IV boluses, which is where, we've kind of followed suit that we're not in a rush to jam this into these animals. I, however, am not aware of any cats experiencing anaphylactic reactions. And when we were first doing our prospective study and I was doing the pharmacokinetics on these cats, I was administering these boluses over 30 seconds to 60 seconds, and we didn't have any adverse outcomes. But I'm not in a rush. So generally, I'm setting this up as a continuous rate infusion for my patients. I'm just going to run you through a case example on, if you are in practice and you're presented with a really debilitated animal, this is such a debilitated animal. This was Milo, who was one of my prospective kitties. He had non-effusive FIP or dry FIP without any ophthalmic or neurologic signs. He was developing hypoechoic rim signs on both of his kidneys and had enlarged mesenteric lymph nodes. We did aspirates of his kidney, and it was coronavirus PCR positive and also immunocytochemistry positive to confirm his diagnosis. But he also had a lot of those hallmark signs on biochemistry of hyperglobulinemia, hyperbilirubinemia, and non-regenerative anemia, all of the sort of waxing and waning pyrexias and weight loss. But he was 3.8 kilos at the time of diagnosis. And so for a dry FIP case with no ophtho or neuro signs, we were going to administer him a 15 mg per kg SID IV remdesivir dose, which calculates out to be 57 milligrams. Now, if you're doing that 2 mg per ml final suspension of, or final dilution of your resuspended remdesivir solution, that equates to 28.5 mils. And if you're going to administer that over 2 hours, that's 1.5 maintenance rates for that animal. And that's again where I think it's really important that you're calculating ahead and then looking back at final concentrations, final volumes, sorry, of the drug that you're administering relative to your patient, and making sure that you're delivering it in a time that's not going to encourage fluid overload. Milo responded really well after the first few doses of IV remdesivir, and so we then switched Milo onto oral GS for 41524 tablets. So if we now want to transition this cat onto tablets, we do the same calculation because we're going to use the same dose rate of GS, so 15 mg per kg, which is the 57 milligrams. Because these are 50 milligram tablets and we need to round up to the nearest quarter tablet, we elected to give Milo 1.25 tablets, which equals 62.5 milligrams, so that he's growing into that dose. So this is him when he sort of first went home after having his few doses IV, and he'd started eating, his pyrexia had broken. He was starting to look more alert and be able to move around the cage freely. Skipping ahead a few weeks, so at week 6, Milo had gained nearly a kilo, so sort of 800 grams of body weight, so he was 4.6 kilos, which meant that 15 mg per kg, we needed to be aiming for 69 milligrams, which means we bumped him up to 1.5 tablets of GS. Go to week 10, where he now weighed 5.2 kilos, so he needs 78 milligrams. We're now going to give him 1.75 tablets. And then this is Milo 2.5 years later, who is a whopping 6.42 kilos and remains quite chunky to this day. But this is just an example of how important it is to be monitoring that weight creep and making sure that you're adjusting the amount being delivered to continue to meet that dose rate requirement. Things that I avoid with remdesivir and GS. The first thing is I don't like my cats to drop below 15 mg per kg per day at any point anymore. We always want to estimate up. Initially, I set that bar at 10 mg per kg, but we were still seeing the occasional case with refractory FIP or sort of breakthrough symptoms on 10 mg per kg per day. So generally, the standard dose seems to be moving towards 15 mg per kg per day, and that's certainly, what was used in the Munich study that I've referenced. We don't want to adjust the dose down with weight drops, and this is how we approach things. There may be some different methodologies out there, but essentially, particularly with our effusive cases, it's quite common that they will drop weight when they resorb their effusion. I'll show you a graph of that in a minute. Essentially, if I start them on that weight and they are resorbing their effusion and get a bit lighter for a while, I tend to hold steady on the same amount being administered and then just wait for them to start to regain healthy body weight for me to adjust up from there. I've revised this statement to say caution stopping treatment before 12 weeks. Historically, I've said do not stop treatment before 12 weeks until we have more information. I mentioned pardon me, that we do have a new publication that's emerged from our colleagues at Munich who have done a prospective randomized comparing 6 weeks of treatment to 12 weeks of treatment with the 20 cats in each group. That has now been published, and it's really exciting to see that out in published literature. The thing that I will say is I mentioned before, there is probably a slight bias in that population to be recruiting less severe cases. And personally, I have definitely seen cats come out of remission with shorter duration of treatment where we've been limited by the finances of the owner. So I am still generally going to be aiming for 12 weeks. But the main thing for me is that I really want to make sure that all referable signs of FIP, so their biochemical changes, their physical exam changes, have all resolved for at least 2 weeks before I'm going to discontinue the antiviral. So if you do have a cost-constrained owner or a patient that's just responded so well and has bounced back to pretty much all normal parameters within 2 to 4 weeks, absolutely, I'm now going to have a bit more confidence to think maybe we can stop at 6 weeks. But I'm reticent to say that all cats can just be treated with 6 weeks, because we have seen cats fall through the gaps even with extended treatment trials. You want to avoid using continued corticosteroids beyond the first 1 to 2 weeks if you can. And The main caveat to that would be immune-mediated hemolytic anemia that can sometimes present secondary to FIP as a complication. Those cats often will need longer duration of corticosteroids. But in general, most of the inflammatory signs that we see that necessitate corticosteroids, like uveitis in our ocular presentations, or sort of depressed mentation in neurologic presentations, most of those cats should be responding quite significantly within that first 1 to 2 weeks of treatment if they're on an effective dose of the antiviral. If their dose isn't high enough, then those symptoms can linger. And I get a lot of second opinions of cats that are still on 3 different types of eye drops and prednisolone, but they're only on 6 mg per kg of remdesivir, which was one of the first published dose rates, which we've now revised. As soon as you bump those cats up to the 15 mg per kg, those symptoms resolve and we can discontinue those. So I'm not saying that if you've got a cat with overt signs that's really painful with its uveitis, that you just stop treating it. But I'm saying that if your cat's uveitis is due to its FIP and you're not seeing a significant improvement in the amount of inflammation, you need to consider that maybe that cat isn't on an effective dose, or you need to switch antivirals, or look for another complication of that uveitis. So sometimes we might see that progresses to glaucoma and, a lens luxation, which is a case I'll sort of discuss in a minute. But just in general, we don't want to leave these cats on protracted corticosteroids, because the concern is that we may impair their ability to mount an effective immune response to help continue to clear this virus and achieve long-term remission. In terms of the minimum monitoring time points that I'm advocating for with these cats, at the very least, we want to be doing a weight check every 2 weeks, or ideally weekly if they're being managed at home. So sometimes we will have cats that bringing them into the clinic is just too stressful or too traumatic, or it's too expensive. I think the fallback is to have, diligent owners invest in some baby scales, some digital scales at home, and be communicating with you what their weight's doing and how they're progressing. But in general, I want to be seeing them, if we can, in practice at least every 2 weeks over the course of treatment. I have said to focus on the clinical response in the first 12 weeks, because sometimes blood results will look a bit worse before they get better with respect to globulins in our effusive cats. And again, I'll speak to that in a minute. Now that we have publications advocating for 6 weeks of treatment in some instances, then I'm definitely going to be doing a blood test at 4 weeks. If I have a cat that's responding really well, I want to know that everything's normal at 4 weeks, so that I'm treating them for at least 2 weeks beyond normalization before I discontinue drugs. So, for those instances, I probably would introduce an earlier check. Sorry, clicked ahead. But otherwise, definitely at 6 to 8 weeks, and definitely again at 10 to 12 weeks, to make sure that things have normalized and they've stayed normal before you discontinue, has historically been how we monitored these cats. And at a minimum, we want to be doing a CBC biochemistry. If you have access to acute phase proteins, you can absolutely include an AGP and serum amyloid A. If you've done a dose increase and you need to recheck, well, you should recheck that cat within 1 to 2 weeks to make sure you've seen an adequate response to that dose increase. And generally, if you do need to sort of do a dose increase, or they've not met your remission criteria by the defined date, I'm generally extending things into weekly increments with them. This is the trend that I've alluded to a couple of times around weight drop and globulins going higher in our effusive cats. So this is specifically for effusive cats. It's quite common that around the point of effusion resorption, which is typically around that 2-week mark, that we see a spike in globulins, a transient drop in PCV, and a dip in their weight. And our hypothesis for what's going on here is that these are often very high volume, highly proteinaceous effusions that are occupying a third space, and that we are, essentially seeing resorption of those proteins and that fluid back into the circulation, which is creating the spike in globulins, a bit of hemodilution that's producing that PCV drop, and then a transient weight drop as they're peeing out that extra fluid. But from there, things should normalize and weight should start to come up. What do we consider to be a suboptimal response? So these are essentially the milestones that I need my cats to hit if I'm just going to continue treating them at the sort of standard dose rate and duration. If we see pyrexia persisting beyond 5 days, I'm going to be tweaking doses. If effusions are still hanging around beyond 2 weeks, I'm going to be considering adjusting things. Hyperglobulinemia, for me, really, I want to see that actually probably normal closer to the 6-week mark. But with the Munich population of cats, both with this new prospective that was published, but also their original paper using mutation, their globulins were often normal by the 4-week mark. So I think there can be some potentially regional differences or just individual case differences, again, whether it's a severity issue or whether there's actual differences in how susceptible the virus is in different parts of the world. But in general, if I've got a hyperglobulinemia beyond 6 weeks, I'm going to be adjusting doses, or any new referable signs to FIP at any stage during treatment. So this was one of our first kitties that was recruited that was on a much lower maintenance dose than we're now advocating for, who kept having breakthrough anterior flare and uveitis that would also correlate with the spike in globulins that kept necessitating dose increases. Adverse drug reactions with remdesivir and GS. There is a potential for ALT elevations. We're sort of seeing like mild ALT elevations kind of reported in most of the literature. In my prospective cohort, it was really hard to elicit whether or not this was like a disease or a drug effect or something unrelated. But they're rarely, or in my instance, they've never required specific treatment. They're sort of not usually more than, more than 1 times the sort of reference interval. So it's not something that's necessarily requiring specific treatment. I don't advocate for any supplements routinely with my FIP treatment, and they all seem to normalize and do well. With remdesivir, injection site discomfort and mild skin irritation are definitely reported, and that appears to be anecdotally more severe if you're using unlicensed GS as subcutaneous injections. Troubleshooting these cases. So what do we do if we do have a delayed response, if they're not meeting that criteria? The first thing you need to do is ask yourself this question: is it FIP to begin with? I'd say over the last 6 months, I've seen a really big shift in the emails that I'm receiving for case advice. It's gone from how do I access these drugs to DVMs that are now seeing cats that have ended up on protracted courses of antivirals that didn't have a confirmed diagnosis to begin with. And we're trying to sort of retrospectively decide, gosh, is this FIP or have we missed the point, and is there another pathology going on? So one, was it FIP to begin with? And even if it was, if you achieved a definitive diagnosis and you're able to get biopsies and immunohistochemistry and it had all of the referable signs, have you checked for another comorbid pathology? Because increasingly I'm starting to see these cases where, yes, they had confirmed FIP, but actually they had lymphoma too, and we didn't request the standard histology. We went straight to immunohistochemistry and we missed the fact that actually there's cancer in this animal. Or is there a secondary infection? Is there a concurrent bacterial component to what's going on with them? It's really important that before we just continue on and do dose increases with these antivirals, if we didn't have a strong index of suspicion as clinicians that these cats had FIP to begin with, then I think you really need to question whether you continue that antiviral or stop and start looking for another disease. If you do have a strong index of suspicion, it's making sure we're not missing something else going along parallel with that FIP. But if you are confident that you're dealing with FIP and it seems to be lagging behind those milestones, the first thing I do is a dose increase by 5 to 10 mg per kg per day. This is definitely when I'd be moving to a divided dose. And if you are in an area that's got therapeutic drug monitoring available, then that's something that I'd request on the animal. But therapeutic drug monitoring is still very much in its infancy, and there's not anyone in the US that's routinely offering this at this stage. So just put that in a watch bucket. This is when I would be considering switching to a different antiviral, such as EIDD1931, molnupiravir, or Paxlovid. And I think we do need to reassess the role of immune modulators, and there are some exciting perspectives that are underway at the moment, sort of re-examining some of these. Feel free to reach out to me though. I talk to vets all around the world on cases with FIP. So if you're feeling a bit stumped and you're not sure, don't be shy. I'm very happy to answer questions. I'm going to skim through this really quickly, mainly because molnupiravir and EIDD at the moment are not legally available in the US. These are the current recommended dose rates that we're using. The big difference is that it's always BID and it's always oral with molnupiravir and with EIDD. Watch this space I've put there because EIDD may eventually be released by Stokes because Bova do it. And I know they've sort of initiated conversations around whether Stokes can get EIDD 1931 into the US. But there's a much narrower safety margin with these drugs. There's a slightly different mechanism of action with these antivirals where they do have a potential mutagenic impact, both from a host and a virus perspective. So you want to be wearing gloves. You need to be careful for adverse side effects. And the main one that we see is leukopenia. So bone marrow suppression is something that we document with higher doses. But there's a lot more adverse effects that we're sort of noting in the molnupiravir literature. Having said that, in some avenues, this is the only legal option. So where molnupiravir has been registered for COVID use, so particularly over in Asia, places like Japan are using a lot more molnupiravir. In Australia, we're using a lot more molnupiravir. Overall survival rates are coming out around 77%, so still a good chance of survival. But for me, I really want to reserve these drugs to be a second-line antiviral, mainly because of the safety concerns, the potential. In human literature, we've seen the emergence of specific viral mutations in COVID that suggests that the use of molnupiravir has created that genetic drift in those viruses. So I think it's really important that we exhaust GS and remdesivir as an option before we move to these second-line antivirals, in my opinion. EIDD, there's been a prospective case series. Similar adverse effects were noted. The doses range from 15 to 20 mg per kg BID in that instance. Paxlovid is the drug I want to spend a bit more time on because this is a drug that DVMs in the US can use off-label. So you can write a prescription for this, and most of the corner drugstores are going to stock this. Like your regular human pharmacies will generally be stocking Paxlovid. Paxlovid contains two different antivirals. There's nematrelvir, which is the protease inhibitor, which has the antiviral action, and ritonavir, which, sorry, isn't an antiviral. It contains two drugs. Nematrelvir is the antiviral. Ritonavir is a PK booster. So essentially, nematrelvir is metabolized really quickly, but it's metabolized via the cytochrome for a P450 pathway. Ritonavir inhibits that, so it delays metabolism and keeps plasma concentrations higher for longer. So that's something that UC Davis are doing some really exciting work with, and hopefully we'll have some publications from them in the next 12 months. But we have started using this in cats that have failed GS, failed molnupiravir, where we're really sort of don't have many other options. And so we've taken an educated stab in the dark as to a dose rate. And what we've been advocating for is essentially a quarter of the human dose rate, which works out to be half of one of the nematrelvir tablets and a quarter of a ritonavir tablet twice daily. We use this in addition to GS or in addition to molnupiravir. We do not use Paxlovid as a monotherapy, but it's definitely becoming my sort of go-to option for true refractory FIP, particularly if you're based in the US. This seems to be the main accessible option, but it's expensive. You're looking at about $1,500 US per box, and that box is only going to last 20 days at that dose rate. I know UC Davis are actually trialing a lower dose rate, so using a quarter nematrelvir and an eighth of the ritonavir, and it may work out that that's going to be just as effective. So that's sort of something else you could consider. But so bringing it all together, how do I decide which things I'm going to use if I'm hypothetically now based in the US as a clinician? Essentially, the first question is going to be, how sick is your animal? If it's obtunded and it cannot swallow, then absolutely IV is going to be your best route, and you need to scramble to try and find either legal remdesivir, or this is, you know, a reality where unlicensed parenteral formulations probably do still have a place at starting to turn these animals around. I would then transition them to GS 441524 to complete a total of 84 days, or if they're responding brilliantly and they tick all of my criteria, then maybe I'm considering a shorter duration these days. If they have a competent swallow reflex, go with oral from the get-go. I don't care what form of FIP they have. If you have a suboptimal response, consider adding in off-label Paxlovid, or owners may source unlicensed molnupiravir or EIDD 1931. And if you have re-emergent FIP, then you can consider repeating GS at a higher dose rate, or this is definitely when I would be adding in Paxlovid, or again, there might be unlicensed avenues for molnupiravir or EIDD 1931. Again, just a note to the DVMs in the audience, don't just always think that an antiviral is the only thing these animals need. Usually for the first few days, they're going to benefit from other supportive medications, particularly sort of meropenem or ondansetron and sort of mirtazapine, to kind of help from a nutritional standpoint, monitor their blood pressure. Some of these guys are pretty hypotensive in the first week of treatment. So just be monitoring these animals as you would for any other sick cat. It needs support. Now, I'm just going to work through one case because I think we're going to run out of time, unfortunately. This is an email case that I've been sort of assisting with, who is based in Australia. But this is a 7-year-old male-neutered domestic shorthair that presented with lethargy, pyrexia, inappetence, a large volume ascites, and a palpable abdominal mass with no ophthalmic or neurologic abnormalities. There was a persistent hyperglobulinemia on biochemistry and an alb-glom ratio in the blood of 0.5. They did fluid analysis and it was pretty high protein. It's 50 grams per litre and the alb-glom ratio was 0.5. It was technically classified as an exudate because there were quite a few cells there. But that's not uncommon for FIP, and it's sort of on my list of things to put some data around and publish. Is not all of these cats are just a pure sort of low cellular, high protein, yellow straw sticky fluid. We do get some that have lymphatic fluid or hemorrhage or more exudative presentations. And the pathologist on the cytology report noted that FIP infection is suspicious, and considering the history provided, and recommended doing a coronavirus PCR, which was performed but was negative. Now, again, I'm not diving into diagnostics today, but unfortunately, a lot of our confirmatory tests do have the potential for false negatives. So we end up in these tricky situations where it's like, we can't quite catch the virus in action, but this cat is meeting a lot of my criteria for a really high index of suspicion of FIP. These vets did do sort of aspirates of the mass, which looked pyogranulomatous. There weren't any obvious bacteria on gram stain. They didn't specifically culture the fluid, but cytologically, they didn't see any evidence of infection, and there was no suspicious cells to suggest neoplasia. So FIP was really at the top of our differential list for this cat, and the owners were not comfortable taking this cat to surgery. They were really not keen to go for invasive diagnostics. I'm going to skip through what your differentials are just because I'm running out of time, unfortunately. But to just continue this story through, essentially, we elected to do a treatment trial with this cat because for an effusive FIP with non-ophthalmic and non-neurologic involvement, 15 mg per kg SID of GS should produce a pretty considerable response in the first week to 2 weeks of treatment. But unfortunately, although 2 weeks later, Fred was much happier and weight was stable and there was no further fever, there was a persistent large volume effusion and the abdominal mass was still there. And again, I'm not going to jump to the quizzes, but in terms of what you do there, you know, we're constantly torn about, okay, well, this is a cat that's not meeting that criteria. Is this definitely FIP? And there was another discussion around taking this cat to surgery for biopsies versus do we go with a dose increase in the GS? And the owners elected to go for a dose increase in the GS. So we bumped this cat up to 15 mg per kg per day. 4 weeks later, cat's still happy, still eating pretty consistently, weight still stable, still no fever, but still has a large volume effusion and an abdominal mass. Now, at that point, we proceeded with exploratory laparotomy. So the vets that were managing this case were able to discuss that we really need to go back and reassess what's going on. There was a mass associated with the jejunum and biopsies were taken. And the histopathology report has confirmed that this was actually a case of feline sclerosing eosinophilic fibroplasia. Now, I've not seen one of these lesions produce a large volume abdominal effusion, but this is just going back to the fact that cats don't read textbooks and they don't like to fit into boxes medically. So this cat essentially received 6 weeks of GS for a non-viral disease and needed to be started on corticosteroids. And we've essentially inadvertently deprived this cat of a rapid improvement in its disease by 6 weeks because we hung our hat on FIP. And I still don't know whether we could do anything differently in this instance, but more and more my inbox is flooded with these kinds of cases where we weren't able to confirm a diagnosis, and sometimes the index of suspicion of FIP is way lower. It could be something as simple as a non-regenerative anemia ends up on a 12-week course of unlicensed GS because an owner well-meaningly found it as a differential and connected with a well-meaning social media group, and the bit in between has been skipped. And this is again where it's so important. If you're not a DVM and you're in this space of FIP, please be directing potential cases to their clinicians to be sure that we're ruling out other pathologies, because things just aren't as clear-cut as they seem. And although our general sort of conversation has been, well, look, we're really happy with the safety profile of GS. Let's just start it because we don't want these cats to get worse. And we know that the longer we delay treatment, the poorer the prognosis in some instances. But if we're not really, really, really suspicious of FIP, I implore you to hold off on commencing antivirals until we've done some further diagnostics, because now we're ending up in this really muddy situation where we can't now distinguish whether or not these are true resistant infections or whether this was never a FIP to begin with. Because what we do know is that once we start these antivirals, any test for FIP is probably going to be negative within a week of starting treatment. So we can't really go backwards without stopping it and seeing whether they get worse. So really do your absolute best to try and be as confident as possible about a diagnosis. And even if you can't confirm the FIP, be confident you've tried to rule out all the other things that could be going on. There was one final case, but it was a neurologic FIP that's been managed over in the US. And I'm just going to run you through more the video progression. Essentially, this cat was given a presumptive diagnosis of neurologic FIP and was started on unlicensed formulations of GS and improved a little bit initially, but then started to deteriorate again when they were switched to oral unlicensed formulations. This poor little kitty became increasingly ataxic, was really struggling and could sort of barely move around at the point that the DVM reached out to me for case advice. And I don't know whether this is going to let me advance my slide because I made my videos too big. Ultimately, we added in Paxlovid in this cat, and this cat responded, started to improve within 6 days of starting treatment. 2 weeks into starting treatment, it was able to jump up onto its scratching post again. And I've connected with these owners, and this little kitty's, now a month or so into treatment. This is his little mate. But you can see we've got tail function again. This cat's way less ataxic. He's, playful and sort of moving around a lot more freely. There was a complication with the eye. Uveitis had created glaucoma and a lens luxation, and then they've needed to enucleate, but this cat's now happy and improving. I'm going to leave it there. Treatment's going to continue to evolve rapidly. So just make sure you're continually checking in with things. And these are some webinars that you can watch back on demand that myself and some other esteemed colleagues in this area have produced in for Stokes for sort of DVM advice. So if you want to touch up on diagnostics, if you want to hear more in-depth discussions on things, you can definitely access those on demand. And if you're a DVM that loves infectious disease, come to ISCAD in Vancouver in October. I'm going to be speaking there. And I will stop sharing my screen and wind up.
Well, thank you so much, Sally. That was amazing and just so useful. We really appreciate this really comprehensive review. And of course, this is an evolving story like the virus is evolving. We have time for one or two questions. I'm going to ask one from somebody that was submitted beforehand. They asked questions about, they had a cat that was treated. He's a 2-year survivor after receiving injections from online, GS injections, and noticed that the cat developed apparent pica, appears to be eating, and is asking whether you've noticed that as a side effect of.
No, that's the first time pica has been raised. I've definitely not heard on it, and I guess my gut reaction to that would probably be it's unrelated.
Okay, fair enough. Here's a question that talks about whether necropsies have been done to track what treatments do to the virus within the tissues of the body.
Yeah, and that's what we're all itching for, but the happy problem that we're having in the prospective study space is that not many of these cats are dying. Unfortunately, the 3 that did die in my prospective, because we always need to work in accordance with owners' preferences around this, and also we were dealing with the logistics of the middle of COVID lockdowns, and there were sort of 2 instances where we just couldn't get couriers and labs to coordinate in a timely manner to achieve a necropsy, or owners have declined necropsy. I know UC Davis have done necropsies in any cats that haven't survived in some of their studies. Just talking to Crystal Regan there, and they're having a really hard time trying to find virus anywhere in these cats' tissues after being on antivirals for usually a week. We did have a really interesting case that was reported out of Germany. So the same group at Munich who did the Mution study back in 2021 using Mution to treat FIP. One of those survivors who was doing really well, sort of 6 months down the road, very tragically got hit by a car, and the owners very vigilantly realized the opportunity from a scientific perspective and presented the cat immediately to the uni for necropsy, and they were unable to find virus anywhere in this cat's tissues. So the suspicion is that we are probably dampening down viral replication to a point where the immune system can figure out how to now mount a competent response to hopefully clear these cats, because I'm definitely not seeing an inundation of re-emergent FIP years down the road. There's a handful of cases I'm aware of that meet that criteria, but I suspect these cats may actually have a more robust immunity to coronaviruses on the flip side, but we need data around that.
Fair enough, thank you.
But if anyone in this audience is the owner of one of these beloved survivors and their cat does succumb to a different disease, although this is a horrible thing to have to think about as pet owners, we never want to be thinking about this, but these are really important cats for us to understand. And I think doing necropsies is going to be really important. And I know there's a lot of institutions in the US that would be interested in this. So if that eventuates, I would really encourage you to allow your DVM to do a necropsy.
Well, thank you. That's certainly very important. This question was probably prompted by the COVID situation. Is there any correlation between cats' diagnosis of FIP and blood type that you're aware of?
Not that I'm aware of. That's an interesting question. I think we really need to dive into the immunology with these cats more, and there's some people working in this space already. And so I think blood type should be one of the many things that we're looking at, but I'm not aware of a susceptibility thing with blood type emerging in the FIP literature today.
Okay. One final question. What's believed to be the mechanism of IMHA in cats? Is this in cats? Is it antigen deposition, or do we have any idea, or do we know?
No. I don't know that we really know. I guess cats are quite good at getting secondary IMHA to any kind of inflammatory process or other disease process. So I'm personally kind of lumping it in the same bag as, you know, a secondary IMHA for other disease reasons. I know a colleague, Petrosana, is collating some cases of IMHA. Hopefully she'll sort of be looking at publishing that once she gets enough cases together, whether we can tease out some commonality in terms of what's triggering it. And I think, again, as viral sequencing becomes a bigger conversation in this space, we may start to tease out that particular mutations might lend themselves to slightly different manifestations of FIP. But at this stage, we don't really know.
Okay, thank you. And one final question. This is sort of a combination question. The risk about exposing cats with FIP to other cats, especially young kittens, will they still be shedding coronavirus and infecting other cats potentially? And I'll add on to that. Do we know, has there been any evidence of a cat shedding mutated form of virus, or is it still an internal mutation hypothesis?
I think we are going back to the drawing board on pretty much everything we thought we knew about this disease now that we have survivors that we can study. And, you know, these are RNA viruses that love to mutate. I think it was naive to think that things would ever stay the same. In general, historically, it seems very rare that cats who are exhibiting FIPV, so actual FIP presentations, are actively shedding infective virus. However, the main thing that's really thrown that into question more recently is a huge outbreak of FIP that we've seen in Cyprus. And there's a big international collaboration underway to flesh out the real the issues of how that emerged, and Cornell are doing a lot of the sequencing for this. It does look like in this instance we've had a recombination with a highly virulent canine coronavirus that has potentially led to a directly transmissible form of FIP. And we definitely have these you know, documentations in the literature of outbreak kind of situations that seem more than just standard kind of we do think there's a genetic susceptibility that needs to be fleshed out. So sometimes litter mates will go on to all develop FIP, but they've been rehomed to completely different environments. We're still figuring it out, but in general, it seems unlikely that an FIP cat is going to directly transmit to another animal in the house. And I'm not actively recommending that you quarantine these cats at the moment if you're not in Cyprus or Europe. But if you feel like you are seeing an outbreak of FIP and there is a suspicion of transmission, reach out to Cornell. Gary Whitaker there, I'm sure, would be doing some sequencing, because we do need surveillance to know whether or not we're seeing new strains of FIP emerge, and are we seeing Cyprus strains hit the US or Australia. So it's another evolving beast, but in general, no, most of the time.
Thank you. And of course, that evolving situation.
Yeah.
Well, yeah, first of all, I want to thank you so much from the bottom of all of our hearts for doing this. This is really wonderful. And thanks for staying a little extra time. Of course, I think that's about all the questions we can get to today. I believe, as you said, the slide deck will be made available. Yes. And
yeah, I've sent through the PDF. I removed the case examples just to kind of streamline a little bit more. But yeah, people are welcome to refer to that. As I said, there are some good watch on demand webinars around how all the literature came to be and what the diagnosis, how to sort of nail down a diagnosis, that is all parked on that Epicure Stokes webpage as well.
Okay, that is so great. And we'll be sharing the PDF with attendees. So thank you so much.
Amazing.
And so in closing, again, we really can't thank you enough for doing this. It's been wonderful. To folks from all around the world who are joining us, thank you so much for joining us. And I know, please keep track of Dr. Coggins's work and use those other resources that she put up. If you have questions, contact us. If we can't answer them, we'll contact her, because she's the expert. Thank you so much. And again, remember, everybody, and here's my plug, the Cornell Feline Health Center, we can only do this with the support of donors. We're completely donor supported. So please consider following us on Facebook and on Twitter or X, whatever it's called nowadays. Join us as a member. And thank you so much, everybody, for joining us today. Without any further ado, I was going to say good night, but I will say good morning to you, Sally. And I
From
hope
the
you have a wonderful day
future.
in the future. Yes.
Yeah.
But, best regards to all of you from all of us here at the center. And I hope you're all doing well. And please keep your eye out for future webinars. Take care.
Thank you.